we'd just like to thank everybody for coming for today's event. It's been really good, it's been really informative, and I think it'd be really helpful for us planning how we move forward.
Yeah, I think it's been fantastic. I think there's lots of feedback we've had today, lots of output from today's event that we need to take forward and try and make sense of. They're really great to see so many different parts of our health system here today, from patients to clinicians to managers, from right across the providers and the commissioners. So fantastic. I think we've achieved a lot in 3 hours, and I think we just need to make the sense of what was said and how we take it forward, the so what.
How they fit in to the future of the Alliance. We spoke about estates and optimising our space across the whole of LLR and how the Alliance fits into that, and making sure that we have cost-effective services, but being sure that we don't necessarily always redesign our services based on that side, but also what the patient need is. Again, around the point of making sure that we don't put every service in every area, but looking at hubs, what patients require in each area, and and rationalising that to make sure it makes best use of both the workforce that we have, but also patient need. There are obvious things around achieving RTT and making sure every organisation that is part of LLR is sustainable by working together. And I think some of the biggest points were around streamlining services and making sure every stakeholder is responsible for their own care. So we've got, the delivery of the clinical side, but also the patient's responsibility in their care. But we think also that the Alliance potentially is a big enabler for workforce redesign. And actually, if we are going to do things differently, that is probably the biggest thing that we need to focus on. And we talked about other things like how the Alliance could potentially even widen to see how pharmacy could help. So it's about that whole journey from a patient initially deciding, do I need any kind of treatment, to then whether or not they end up within a care setting.
Thank you. Any comments on that from anybody? Right, next table.
Very similar themes, really. I think, like the other table, keen patients to be in area where appropriate. I think something we want to build on is the idea that some services come as a package, and although we have an ambition to move things out, let's say like home services, not everything in that can be moved out appropriately. So we don't want patients to have to go for one particular part of the pathway to one hospital, then to another part of the hospital. And it may be actually there is merit in keeping something central in the hospital for a reason. What else? We talked about building can use their full facility, and also if activities moving out, making sure that activities is well resourced along the whole pathway. So speaking to GP, if we're going to do more work, actually that work needs to be resourced, time needs to be made up for it. And training the workforce, like you said, it needs to be aligned to the whole process, and that's going to be a whole thing to get right. Oh, is there more on stage? There we go. I'm really summarising all my holiday.
Yeah, you did, Richie.
I did, yeah. So federations is an interesting piece that some of the federations are at different stages of maturity. So in the city I can think of 3 quite different stages. So it may be that as we move things out, we need to stage how we do that. And we talked about public expectations as to what we can achieve. And I think that's part of that communication piece and being really honest that we can't have every service in every site. What have we got? I think that's it. I've covered everything.
Yeah, we did actually say as well that if we're going to have a facility in the locality, that all the equipment, the appropriate equipment is available. They actually go to several areas now with the clinics, and they can't actually perform the full service because they haven't got the equipment. So we need to make sure that the equipment is there for all clinicians to be able to use.
Thank you. Your table is speaking over there.
I think
Thanks,
very
Helen.
similar to what we've said so far, really. Again, a lot around the appropriateness of services. We did have quite a big discussion about equitable services, timely, etc. for everyone, but recognising that, you know, there is this thing about appropriateness, and it wouldn't be appropriate, like other people have said, to have everything in the community, and some things make absolute sense to be in the hospital. And actually, we had quite an interesting conversation about actually the city. The city is, the hospital is the choice for city patients, and you don't need to forget that in some of these discussions. I think, like some of the other takers, we had that discussion about could the principle of sort of like the alliance type people working across organisations be expanded to other areas, so not just planned care. So Rachel was talking about, you know, the sort of the work that some federations are doing around test beds in the West, sort of, you know, that whole sort of frail elderly and care home works. So some of that, sort of looking at geriatrician, so the integrated community services, could we think about working in a similar way together? Again, similar to everybody else, seamless pathways. Patients don't want to feel like they're being passed between organisations. Probably this was more in answer to the second question about what do stakeholders want. Perhaps utilising the different LPT pillars and declarations potentially on CCL, and making use of the skills that are out there more going forwards. Interoperable systems, I think, again, we've mentioned. And really, have we got a shared vision across us all? Certainly we've seen around, you know, the CCGs and a lot of different providers and looking at sort of the development of the MCP. Is that the alliance vision? And are we actually aligned to what we all are working to with that kind of view? So,
Yes, thank you. Right, the last table here.
Very similar to what you've just been hearing, really. Some of it was about some of the more difficult decisions and just doing it. We're doing quite a bit of talking, and we know what needs to happen, but we don't want to just do it, and actually it's having permission to do it. And we gave a couple of examples, say, endoscopy, moving out of the general into St Luke's, for example, and it is going to be difficult, but things do need to happen. Mapping out capacity, what we currently need, and increasing capacity in the future. So that gap analysis and having the staff. By default, we ended up doing a bit of a pest analysis, really. The political environment obviously is affecting some of the decisions, and the economic environment, the HEAM funding not coming so much this year, so the ability to train staff to undertake new roles is slightly limited, and that is a big issue. The workforce is a big issue, the lack of GPs. So there's an absolute passion and want to deliver far more activity in Care Act as a community, but those political, environmental, technical issues, etc., are quite big barriers. We talked about the appropriate, well, what was it? We did the 5 A's, didn't we? An appropriate appointment at the appropriate time with an appropriate clinician, but the right person seeing the right clinician. Primary and secondary care clinicians to have responsibility or ownership for each area and specialty, a bit like we were just talking about the process of care. Help me out, guys, because I didn't look at what was being written down. Yeah, that's the pathway bit again. I think what we just talked about. What do GPs want from the Alliance? Lead GP for each specialty. Again, that goes back to what we were just talking about. Ownership of the patient, making sure there's some consistency, united view. And then obviously go back to the technical environment, having a seamless IT system, which we're able to link and see. So if we are doing work, say at Hubble's coat surgery, that we can use the same IT systems that we're using in the Alliance as we are in the UHL. So it's a seamless IT system. So actually we ended up doing a bit of a past analysis of the whole thing. Anyone else want to add anything to that?
I think the other thing was that we still need the blue sky thinking. It's not just transferring A to B. It's a different way of doing it, and then actually getting on and doing it if there is a better method.
Right. So there's some emerging themes, isn't it?
So
Yes.
One of the things to think about a unified vision across primary care, whether that's the federations or the VCL. And I mentioned the fact that maybe this is the STP, the Sustainability and Transformation Plan, might be a way of influencing that, because I do believe there's primary care group has been set up within Impact to look across LLR about trying to bring primary care together a little bit.
Right. So the emerging themes there are actually quite sort of the synchronicity, isn't there, between the different tables, and we're looking at, yes, it's the right thing to do, but actually you can't put everything anywhere was one key theme. So we've got to look at what's where. The other thing is it shouldn't just be about a lift and shift, it should be looking at a lift and redesign. The workforce is a key thing, and then that clinical leadership across the pathway, and so that actually it's not about, you know, she'll look after you if you're here and he'll look after you if you're there. It's a bit more of a continuum. There's the whole thing then about that primary care element, because we've got federations coming online. There is the LLR PCL sort of pillar contract, so it's how is that going to work going forward, so we get that primary care, and the STP is a good point there, so that how we bring that together. There's the other thing about making sure that actually if a patient's going to X, they can get more or less all that they need of X done in that area, and they're not having to, you know, I mean, my classic example was when we had Ashby Hospital. You could go and have your appointment at Ashby, but you then have to go for your x-ray to Colville to come back for your follow-up, which is ridiculous, and that's the sort of thing we want to avoid. They seem to be the themes. Have I captured everything from what you sort of said this morning, do you think?
IT.
Oh, and IT, yes. How could I forget IT? And yes, and that connectivity, because it is interesting, because I can't think how many systems we've probably got across LLR, but it's in the hundreds, and probably towards maybe even nearly 1,000 of different systems everybody's got, because actually, and also, I know from my previous experience, if a clinician designed this system and he spent hard love and time to do it, prizing it out of his hands is like, well, terrifying. So there are those challenges as well. Can you stand up so that you can get you on camera?
Right, definitely sitting down there.
You could probably
Okay, so we've got about three areas to focus on. Firstly was in terms of developing a speciality group for each specialty with each discipline. You know, in order to feed into that, there would be leaders from primary care, you know, community care, management, and secondary care, and they would be responsible for developing a framework and a vision for that speciality, and driving that forward within a defined time frame and be accountable for that in terms of the delivery, and have the opportunity of being able to you know, provide information through things like PRISM in order to facilitate those processes.
Can I ask a question on that?
Yeah.
How do, because in a way we have tried to do that in the past,
Yeah.
but the truth is it's been hard to get, the project managers will tell you that, to get that team together because of everybody's competing work commitments. So did you come up with a, how are we going to make it happen in a timely fashion by actually being able to free anybody up?
Not really. We recognised there were certain challenges in terms of freeing people up in order to undertake roles, either both in terms of clinical delivery or development, and there's an aspect in terms of backfill payments and things like that. You know, people are not going to necessarily leave their own practices in the lurch for a day or half a day a week without being able to...
what I think would be useful from us, and that's what we've got the transformational monies for, but we need to know what is realistic. If you're working on a specialty, what is a realistic, you know, number of meetings you'd need to have so that you could then set the backfill up? And is that just for the GP or is it also for the consultant? You know, because there's still that bit of...
Sorry, can I just ask, what are you asking the people at the groups to do? Are you asking them to go away and deliver something, like give them a task, you come back to the group and say, you know, these are the answers we need to bring it all back together? Or are you saying, it's a bit like cart before the horse, because we don't have a service review which highlights what the issues are before we come to the table. How do we start to say to people what we want them to go away and use their time for? It's got to be productive.
Well, I think the idea is that you'd have those leaders who would have that understanding of where the Alliance, Better Care Together, is directing. There is a vision, and that vision needs to be, based in a service specialty. And presumably, if they are a GPSI in that specialty or a consultant in that specialty, they will have that understanding of the challenges within that. It has to be underpinned by information and data that we can trust, admittedly, and capacity and demand and all those types of things. But in terms of the direction that we're looking at going to, they probably can apply, that sort of sense check that, in my speciality, taking loads of GAs out in the community, bad idea, because that's just not going to work. So until you're relying on that, on that specialty understanding for that.
Just the other bit for me was, it's not just really totally about what we put out in the community, it's what happens within the patch, isn't it? Which is the Planned Care Ambulatory Centre in UHL, so that actually we help to size that bit of it, so that actually we look, because what we don't want to do is look at the patch in glorious isolation internally, and then what's happening in the Alliance in glorious isolation there. We need to do it together. Does that?
I think that where those things have worked well and where developing pathways has worked well is when you've had clinicians from primary care and clinicians from secondary care who both have the same vision and who are committed to changing that pathway from one end to the other and have a shared vision. And I think if that means that we have to provide UHL clinicians or LPT clinicians or GPs the time to do that, I think that's going to have to happen. Otherwise, we're just going to be doing things piecemeal, and we're going to be in the same position in 2 years' time.
Yeah, and can one GP represent all 3 CCGs, or do we think we'd need a GP from each CCG? What do the GPs think? If there's any left. Hillary?
It's quite difficult as a single GP to represent all 3.
So you'd need one from each, do you think?
Well, no, there are other ways around it. You can do it, it's hard, but that GP needs quite a lot of time to talk to other GPs around different areas. You can do it.
I mean, that takes us on to the second thing, which is the communication aspects, because it's all well and good, half a dozen people deciding this is a really great idea if there then isn't buy-in, across the patch. And so, there does need to be ways of facilitating input into that group, ways of expanding, the vision into the wider population through a variety of routes, and that two-way communication was felt to be something that was going to be fairly critical. The final thing, the final priority, we felt was really in terms of workforce development, and again, one would have, an understanding if you're looking at developing, for example, a triage process, you're going to need a certain number of people to support that, and that may well, take them out of work for education and for development and for ongoing mentoring. And again, we were talking about the most appropriate person, and so that isn't necessarily going to be a doctor, but it might be a nurse or it might be a physiotherapist. But again, those sort of processes when there isn't a very formalised process for developing those skills. We're saying, how do you become a GPSI in X? Well, nobody really knows anymore, but there are probably some good ideas out there which are probably reasonable, but it's not a formalised national structure or anything. But we do need to obviously support people in terms of developing that, particularly if we're going to be using that type of person further.
So do we need somebody to do a recce about what's available nationally, do we think, in various specialties that we could utilise? Would that be a useful thing to do, or should we rely on...
That there are some educational opportunities that would be sensible, but it doesn't necessarily allow you to tick that box. And getting up to a certain standard is only one thing, and then it's a matter of staying there as well.
That's very true. Right, thank you. Table at the far end there. Table 2.
Green table.
You're the green. So who's reading back for the greens?
I'll do it then.
Stand up then,
so
so if you can see you. He wants to film you.
Oh no!
Yeah, Sarah, you're glamorous.
We struggled a little bit actually. Went around the houses, I'd say, and we had quite a discussion about the different level of services that are provided in different locations. So there's something for me about understanding all of that, because we've got a bit of postcode lottery going on. So if you're in the north, you can access injections within your GP practice, but if you're in the city or wherever, you can't. So there was some discussion about that. We also had quite a bit of discussion about how do we engage with the new bodies, the federations, as they're developing and they're on board and viewing and understanding more about what we're trying to do and deliver. But the three things that we identified was practical steps was around revisiting specialist level plans, and you'll remember the sessions that we had, and having learnt from some of the pitfalls that we've gone through in implementing things like the MSK triage, the ENT, the ophthalmology services and the shifts around those, actually could we do the next lot quicker now because we've learnt a little bit more around those. Obviously better patient engagement, making sure that those plans are done with patient engagement. And then in terms of getting stakeholders involved, because stakeholders change with different agendas and new initiatives that come predominantly from the Department of Health and centrally, how you can't have a member of every single one of those on a board. It's just not practical. The board would be too big. But actually, how do we develop an engagement for them maybe, so we can bring people on board quicker. And then we had a bit of a, we're at the point now where perhaps need a bit of transparency around some of the organisational boundaries we've got, not just from the IHL, not just from primary care, but from all of those boundaries, because we all have them. That's it.
Oh, thank you. We're at the back table.
We took each of the sections in three, so they're sort of intermingled really. In terms of engagement, we talked about using the CRG, and on this table we talked about how the CRG started off, and the remit of it wasn't as clear as it has been over the last sort of 6 weeks, I would say, rather longer than that. And it being specialty based, and we feel that this group could be quite key in terms of engaging, sharing ideas and developments. We talked about newsletters and how there's lots of newsletters being done and often people don't read them. And then sort of framing pathways, so it's how you sell the idea of a pathway of development to understand all the perspectives, and engaging the federation, patients group and using technology. And we sort of talked about things randomly really in a way. Working with primary care and federations, so upskilling of staff, workforce, increasing patient information, using social media, e-learning technology. The GP that was on this table talked about using the OLR PCL board as king, because there's representatives from each of those groups. That might be a forum that we can actually use to communicate all the things that have been happening, where lessons can be learnt. And one of the ideas that you talked about here was adding learning needs for GPs as part of their education, so they would have
about their professional development, so putting in that maybe they have to do some e-learning modules, or they have to not read newsletters but form communication so they don't ignore things, if that makes sense. There's a lot going on out there, and they don't necessarily have time to get involved. Just think about whether we can build something in their portfolio.
So it would be specially driven, so then we'd get that representative from primary care, because they'd be driven to achieve that and work with all of us around pathways. A very key message is simplifying it, everything, communication, pathways, it's easy to understand because everything's very complicated, everybody sees it very differently. And using patient power, I think we need to use patients, because we're all patients as well as providers in the room, so we can go to our provider and talk about our experiences ourselves. So the three key steps that we talked about is simplifying and standardising comms. I think maybe we should have one newsletter that goes to everybody, so that everybody will read it, because they will think actually this is where I'm going to get the information from, and that's quite a broad step. But instead of a GP newsletter and a Lights newsletter and a UHL newsletter, why don't we just have one
We spoke about the newsletters as well, actually, but the concern we had about that was information giving, not a kind of collaboration or getting that kind of feedback as well.
Sorry. So better use of the CRG, you know, that is a massive opportunity, and it's about communicating what the CRG is about. And Jane talked about her practice with the view that GPs didn't really want to go along, but as the forums change, the messages go out there again, it is worthwhile them coming because it's
We
a
talked
key
about that as well.
group.
We talked about giving more notice about the CRG because it's much easier for GPs to attend if they're given much more notice beforehand. If they know what their forum is going to be about.
Yeah, I think the most recent CRG, because it was specialty specific to dermatology, and there was an invite out to GPs with a special interest in dermatology, we got very good attendance, and we talked about whether having special invites or having a list of GPs with special interests would facilitate getting better two-way conversation of CRG. I think that is going to work.
I mean, this is what's here, and then we talked about multi-involvement regular groups. This is quite far-reaching. This is patients, target monitors, providers. So, I mean, a lot of ideas are coming out today, and people are glad that they're here because they're hearing about things they've not heard before. So we just think of a way of growing that in some way. Anything else, Bob? No?
Thank you. The group to my left at the back.
We quite easily have Bob on our table, so we continued with the discussion on the presentation and just worked out, how do we think that's working, what we think the barriers were, and therefore how the Alliance can help that. We talked a lot about the IT needs and around information bouncing from one department to the other, and therefore that means the patient is also bouncing around the system. A lot of our discussion was around clarity on how we get from the point of this is an idea to making it happen, and how the Alliance can facilitate that process along with the other boards that are out there. I think what became obvious is we don't share still fully as every individual organisation what our plans are for the next year, what we've been commissioned to provide, that actually the commissioning of services is not necessarily consistent and joined up. So things around physiotherapy services being given notice at LPT but not to UHL, and then how does that link in with the whole pathway, the triage pathways that we're trying to introduce. So that links into contractual requirements. And then we talked about the business cases and the planned care board, and I suppose the question from our patient representatives is, well, why hasn't the MSK triage just happened? Why aren't we there yet if it's actually a national recommendation that this is the right thing to do? We talked about as LLR, we have signed up to a way forward, and we should be all aiming to that rather than going through multiple boards. Should we be giving the ideas to commissioners for them to sign up to the principal vendor in a business case? Have we got that process right? And I think it's a question. And have we got the process right at the Planned Care Board then to pass on to the Alliance? So it was a mixture of things, but still quite clear that we don't do things very quickly. We go through lots of steps, and actually we've got a really great idea that's been nationally endorsed, and we're not doing it completely. Is there anything else?
That's it. Right.
So one thing is
Yeah.
a real key rate limiter with this is being able to bring clinicians together. I think it's something that Kevin's table picked up on. And just a really, really simple idea that, from September, all clinical leads representing their department who are involved with discussion about services design should leave Thursday afternoon to do it. The department should work around Thursday. I choose Thursday afternoon for quite a time in general practice, statistically. You're not going to get anybody on Monday or a Friday. I don't know how it is in secondary care, but if there was agreed, that's the day we do it, and we aim towards that, I think you have a much better chance for project managers getting everybody to turn up, or turning up on time and then not dashing off half an hour before the conclusion.
Good point.
Yeah.
Right, let's take it.
So we sort of focused mostly around the clinicians, and we identified them as the key sort of driver for making these things happen, making these changes. One of the things we thought that really would be important is for them to understand and see evidence of good change and good outcomes, and giving them that information so that it can actually, it gives them encouragement and belief that they should take these things forward. I think the same themes about doing things, just seeing more, getting more doing happening was really important, because there's lots of talking, and I think people just get a bit sort of bogged down in all the talking, and so I think to get the clinicians engaged into that process, they need to see more things happening. One of the things we thought would be important is when you've got the key clinicians on board, is they can see a lot of the visions of a lot of the pathways and some of the more innovative and creative approaches and answers, but it's then giving them the right support at the right time to break down the sort of bureaucratic obstacles that were always there. So just keep saying this is the next part of the governance process, or and we also wanted to say, well, really be clear on the decision-making process or the empowerment process. So if they feel as a clinical group that this is the right way forward, this is the decisions that they can make, and they are empowered to do that, and they can do that, and that should help quicken that process up. We sort of looked some of the things about how we can work effectively is to get more cross-organisational sort of vision across from the key people, including the most senior people in organisations. We referred to about the better communications and PR about all the good things that are happening, and sharing best practice. One of the things we thought of was in terms of sort of that would help things, is that we described as Alliance Mythbuster, as in what does the Alliance mean to people, what it doesn't, and actually a sort of a crib sheet of those sort of things, so it can be shared for people. And the other things we thought was the organisations could have Alliance champions, because these are complex and there's lots of different things that you're trying to, different other organisations, different functions, and you need experts almost in certain areas to help people along the way. And if they're visible to people, you can go for them for a bit of advice, or they've done it already in another project or another example, and they should be more visible, and hopefully people can engage with them. We thought of really seeing as sort of an extension of the Mythbuster, almost as a really good practical example that you can really see. You can walk the walk, see the numbers, see the IT implications, and actually really sort of make it sort of transparent for people about the processes that need to happen. In terms of the key next steps, I think we all need to understand a bit clearer about some of the business processes and finances about some of these things, and I think that would really help to have consistency and clarity on that. One of the things we thought also is, in the ones that we are going to be doing, let's prioritise the big wins. Let's really make sure that we're doing ones that will make a big impact and focus on those, because if you've got a big impact, that will cascade to the rest of the organisations, and it will just be a snowball effect. And look at what ways of sort of break down organisational boundaries, and if there's any sort of shared posts and those sort of things.
There's quite a lot of good stuff there, but it's how we start to work it together, and how we start to actually plan across the board. And I think that's quite key. For me, just as an observation from myself, is that actually we've done very well at silo working, because that's how we've been brought up, and I was brought up the same way. But in reality, it's a bit like we've had discussions with the patch team, that in reality we need to be engaging the specialties together with probably primary care colleagues to actually then map out what needs to happen where and what would that pathway look like, and we need to do it together, which will allow then all of us to work through that, and then things like the scoping of the patch, i.e. how big is it going to be, how much capital would you need, would fall out of that. And actually then what can we do in primary care, because I think there's lots of things about federations and what they'd like to do, and we need to all do it together, and I really do think we've got to come up with a way of making that happen over the next, quite quickly truthfully, because we've done it a bit. Michael said earlier on, we've scratched the surface, we've done a bit here and a bit there, but we really need to develop pace and actually get some really big wins, as you've described, out there, because really we've had smaller wins to date, and that's quite key, and we need everybody in this room and others to work with us on that. And really that would be my summation. And the workforce is a key thing. You can't get away from that. We've got to really make sure we've got a workforce fit for the future. And I hand over, yeah. I've done well, you know, I've not gone on, you know.
I never know whether I haven't stopped or just paused. Take a breath. I think just before we finish and have some lunch, tell me to go this way. Good at following instructions. Just before we finish, just 2 or 3 things from me. Firstly, before I forget, thank you. Thanks to Helen for leading the day. Thanks to you all for coming. Thanks to Rob for the clinical presentation. And thanks to the Alliance team that made the event happen. It doesn't just come together like this. It's been great to have so many people here. So thank you, first of all, before I forget. In terms of the content, I mean, fascinated by what's come back in both the feedback sessions earlier today and just now. And there's everything on the table, isn't there? From pathway stuff to how we work together, to communication, to breaking down barriers. You know, it's all been out there, and a real mix of feedback. I'm glad there are some themes, but also I'm glad that there's a real diversity of views and suggestions about how we make it all better. So that's great. In terms of how we take this forward, I think I owe it to you just to say a few words about what we're going to do from here, because it's great to talk about it for 3 hours this morning, but equally I think it's really important to be clear about what we're going to do, and those of you that know me know that I'd rather be thinking about what we're going to do next and the so what than necessarily talk about it forever. So for me, firstly, we're going to write up the day. Obviously, we've recorded most of the content. We've got your notes from today, and we've heard what you've said. We're going to write that up. I certainly want to see quite a detailed summary of this to go to the leadership board of the Alliance. I think it has a place at the planned care work stream, and it's fit to better care together. And I think we just need to make sure that people who lead our system basically can see and hear what you've contributed today, because I think it's really important, and I don't want this to be lost in any way. So I think that's really important that we do some of that. I think when we will share with you how that gets written up. Again, I think you owed that for your contribution, and I think it would be useful at that point, Helen, if we can do just another reiteration and say if we've not captured it correctly, or if you want to add to it, or you think of something else, then please feel free to then just add that and send us a note back. But I think it's been fascinating. Thank you. I think the mix of people we've had in the room, I should have said this right at the start, but the mix of managerial folk, of clinicians in all types of healthcare from our patch, patients, I think that's been fantastic, and I think that's really led to the diversity of view that's come back to us.